Hi, good morning, everyone. I am Neha Basin. I'm a pediatric hematologist oncologist at UCSF Oakland. Sorry, I have to be here. Um, and yeah, welcome to this session. Dr. Blake, you want to introduce yourself too?
Yeah, hi. I'm Dr. Osborne Blake, internal medicine physician, and I've been taking care of sickle cell patients at Kaiser West LA, and we run the Southern California um, section of sickle cell adult sickle cell care. So we cover the region of Southern California, and I'm excited to be here to just one, learn more about the new therapies that are out, and like the last maybe decade of sickle cell has been so exciting. There's been three new therapies out: voxelotor, crizanlizumab, and Endari, and two new gene therapies with a few more on the horizon, and also the expansion of bone marrow treatments for sickle cell. So these are very exciting times for sickle cell, and I'm just um, delighted and elated to be here at this point in time. And I'm hoping that we could learn a lot from our speakers and catch up on the what's on the horizon. So I'll hand it over back to um, Dr. Nasir.
Okay. Yeah, great. Thank you. I definitely second what Dr. Blake just said. You know, we have such an exciting time in sickle cell right now from a medical perspective. Uh, Back, I think when I was a fellow, there was nothing. Hydroxyurea also was not even a standard of care when I was doing my hematology training. And that was only being offered to patients after they had been to the hospital multiple times and had pain. And then I finished my fellowship, and I remember the NHLBI 2014 guidelines came out, and I followed it like my Bible. I felt I had something to offer from the medical team, things to prevent complications of sickle cell. And I think that's what gave me hope. I'm a pediatrician. I strongly believe in prevention care. And I felt since then, all this field is moving forward and we're doing more and more to prevent. And we're really excited that not only we have more and more therapies for prevention of complications of sickle cell, but also transformative therapies that are going to change the lives of our patients, no matter what age they are, which is very exciting. So to start out this session, we're going to have Dr. Ami Patel from UCLA Health present SC101, talking about pathophysiology, complications, pain management and treatment, and the psychosocial component of sickle cell. It's a very heavy talk, I understand. And so we're going to take pauses in the middle of her talk and open it up for questions. So we really welcome audience participation because that's what's going to make this session even more exciting. We as medical professionals go to all these medical talks, and we know it's heavy information and it's a lot of information. So please ask questions because that's what's going to make it exciting. You guys will make it exciting for us. All right, I will welcome Dr. Patel to come up and chat.
All right.
Are we back
It
on?
looks like we are backing up.
Okay, awesome.
Thank you so much. Give our tech team a round of applause. So fast and so quick.
Am I waiting for the intro video or should I share my screen?
No, you can go ahead and share your screen.
Can you see my screen?
Yes.
Yes.
Well, thank you everyone for the introduction. I'm Ami Patel. It's been now 9 or 10 months that I've been at UCLA. And I am both, I'm a sickle cell specialist. And so I do 100% of my job is just sickle cell disease. And so I've been tasked to talk about sickle cell disease 101. So I know it's a very general, very broad topic. There's a lot more to cover than just sickle cell 101, but we'll give a little bit more of an introduction. I have no conflicts of interest or any financial disclosures. So I'll start by talking about the statistics and healthcare inequities, the pathophysiology, complications, mostly focusing on inpatient complications, pain management and treatment, as well as the psychosocial component to sickle cell disease. And so here's just a little bit about the statistics of sickle cell disease. So sickle cell disease is one of the most common inherited hemoglobinopathies in the United States. So more than 100,000 individuals are living with sickle cell disease here. Globally, sickle cell disease affects more than 8 million individuals. The projected life expectancy is about 54 years versus 76 years for individuals without sickle cell disease. And this also varies state to state. There's excess morbidity and mortality, which is tied to acute care utilization, hospitalizations, and readmission rates. And so focusing more about some of the numbers in the US, it affects racial minority groups disproportionately. Sickle cell disease occurs among about 1 out of every 365 Black or African American births. Sickle cell disease occurs among about 1 out of every 16,300 Hispanic American births, and about 1 in 13 Black or African American babies is born with sickle cell trait here in the US. And there's a high proportion of individuals on Medicaid, about 46%. So let's talk a little bit about the health equity with individuals with sickle cell disease. So adults with sickle cell disease, they're medically and socially complex. They experience significant health disparities among their lifetime. And upon entering adulthood, many of these individuals lose their primary medical home and health insurance. Additionally, there's a lack of adult providers who have received sickle cell disease training and are willing to take the time that's needed to really treat the complexity of this disease. And so patients are suffering from a shortage of specialized, knowledgeable providers, and they have difficulties just in care coordination between their primary and now starting to sort through all of their different subspecialty care as they start to age. And as we know, and I think this statistic has been brought up at pretty much every single sickle cell disease event, but it's significantly underfunded. I think that funding has started to change in more recent years with sickle cell disease, with more research going into it. But in general, there has been less than half of the funding. And so individuals are not benefiting from the comprehensive centers as well as the overall national funding and private funding. So some of the challenges, like I mentioned, lack of specialists who treat adolescents and adults with sickle cell disease. There's inadequate reimbursements for adults with sickle cell disease care that's preventive and team based. And so, me spending 3 hours with my patients for a new visit is not reimbursed with the proper RVUs that are needed. And so, a lot of providers will not be giving the time needed because they're not adequately shown in their productivity. Additionally, there's few adult sickle cell disease centers for comprehensive care and for centers of excellence. There's a lack of knowledge and research. So when someone comes in, they say, I'm experiencing this sort of challenge. A lot of times, the physicians don't know. We troubleshoot, we try to figure out, but there's no great management, for example, on chronic pain management techniques. We have some, but I don't have the answer for everything. There are some, knowledge and research on preventing and treating organ dysfunction, but we have a long way to come. There's also a lack of great transition from pediatric to adult subspecialty care. All right, so this is, I thought, kind of a funny comic. As I switch gears and talk a little bit more about the pathophysiology and genetics. So Frank was famous for his anti-inflammatory rhetoric as he put everyone to sleep. So I'm hoping I don't put you guys all to sleep as we switch gears and talk a little bit about genetics and pathophysiology. So as you all know, sickle cell disease is autosomal recessive. And so both of your parents need to be carriers, either trait carriers or have the disease themselves in order to have an individual with sickle cell disease. And so if both parents are carriers, then you have a 25% chance that your son or daughter will be living with sickle cell disease, and 50% chance that they will be carriers themselves. And that odd increases if one of the parents has sickle cell disease themselves. And so a little bit about the physiology review. I'm going to try to steal some of Dr. Henry's physiology talk to make it a little bit more interesting and more digestible. And so this is a hemoglobin molecule. It's composed of 2 beta globins and 2 alpha globins. And so there's 4 heme with 1 hemoglobin molecule. The heme is what carries the oxygen. And so hemoglobin A, that means normal hemoglobin. It's composed of the same components, so 2 alpha globin, 2 beta globin. Hemoglobin S is that there is a mutation in that beta globin. And so on the 11th chromosome, there is a single acid mutation. And so it switches the amino acid from glutamic acid to valine. There's other hemoglobinopathies too. So it's not just hemoglobin SS. We have hemoglobin C, which is a glutamic acid to lysine switch. And we have beta thalassemia, which hinders the production of mature RNA. And so with beta thalassemia major, there's no beta globin production. And with minor or plus, there's some beta globin production. So it reflects on your hemoglobin electrophoresis. So my big take-home point here, though, is that when you're pairing any of these hemoglobinopathies to a hemoglobin S, this is still called sickle cell disease. So there's so many different types of hemoglobinopathies that are still called sickle cell disease. You have SC, SS, S beta thal 0, S beta thal plus, SD, SE, and there's an entire registry online with thousands more that they're still even coming up with and determining what type of variation is. So you can just see the complexity of what sickle cell disease is. And then you obviously have sickle cell trait, AS, which we're still learning and understanding what impacts trait has on an individual. I won't go into that here today, but it's still pending further investigation and research. And so when you diagnose it, every individual needs a I don't know why it says human electrophoresis. It should say hemoglobin electrophoresis or hemoglobin fractionation. And it separates by size. And so when you are an infant, you have something called fetal hemoglobin. You had that before you were born. And when you were initially born, you have a lot of fetal hemoglobin, and it starts to really diminish at the age of 2 years. So a lot of times when you're looking at a hemoglobin fractionation at that point in time, it may differ to then when you're an adult or when you get a blood transfusion. So just keep that in mind. The way you run it more technically is that you look at the weight distribution on the actual strip. And so your hemoglobin S will be at a different point than hemoglobin C, for example. So this is a very busy slide. I'll break down the components, but the main things I want to highlight are the things in blue. So these are all the different areas that sickle cell disease can affect. And I just wanted to show this one big slide because that means there's one, a lot of different targets for treatment, but two, sickle cell disease is complex. You have one single amino acid mutation, and it causes all of these complications. So you have hemoglobin S polymerization, hemolysis, and vaso-occlusion. And so again, here with the hemoglobin molecule, where it starts. So you have your sickled beta globin, and what happens in a deoxygenated state. So when someone's stressed, any sort of trigger that they have, either that be cold, or if they went in the pool, or if they had too much extra schoolwork, or any sort of level of cortisol that's going in their body, it can cause this deoxygenated state where the hemoglobin molecules become more hyperpolar and they stick together. So what happens is it forms these linear polymers, and at this point, it could potentially be reversible. However, when it goes into a fully sickled red blood cell, that's when it's no longer reversible. Then you can have vaso-occlusive episodes. So now once you have these sickled red blood cells, they're a lot more sticky and they can stick and cause occlusion. But it's not just the red blood cells that are causing the occlusion. Everything is slightly more sticky. So your leukocytes are also more activated and have abnormal adhesion properties, and your platelets are also activated, leading to a procoagulant state. And then you also have endothelial damage. And just when you have your red blood cells that are breaking, that also is leading more inflammatory markers and cytokines that are causing more stickiness, is my medical term, that can lead to this vaso-occlusive crises. And then this is kind of where how having vaso-occlusion, it's a blood disorder. Blood goes everywhere in your body. So you're having that vaso-occlusion happening in all areas of your body. And so it's affecting every single organ. So now going back to this complicated slide again, you have your hemoglobin S polymerization, the linear polymers that are forming that then cause the sickled red blood cells. You have your hemolysis. Once you have the sickled red blood cells, it's now breaking down in 30 to 40 days compared to the typical 120. And then you also have vaso-occlusion. So it's really important to identify the hemoglobinopathy because it can cause a spectrum of sickle cell disease complications. On one side, you have hemolysis and endothelial dysfunction that are more common with individuals with SS and S beta thal 0. That causes a higher hemolytic rate. That causes higher, just in general, breakdown of hemoglobin, higher reticulocyte counts, higher serum LDH, bilirubin. And this hemolysis is more consistent with having complications like pulmonary hypertension, leg ulcers, stroke, priapism episodes. Then on the other end of the spectrum, you have viscosity and vaso-occlusion. So you have lower hemolytic rates, but you still have complications. You typically have higher hemoglobin, but that does not mean that you're excluded from having sickle cell disease complications. You're more likely to have osteonecrosis, retinopathy. And so there's other things that can modify this as well, like having alpha thalassemia trait or other single nucleotide polymorphisms that we're still identifying. But this is a spectrum. So I'm not saying SS always has to fall on the hemolytic side and that SC and S beta thal plus has to fall in the viscous vaso-occlusive side. That's why every single sickle cell disease individual is different, and it's really important that you understand the spectrum. So there's been a lot of progress in general in reducing the mortality in sickle cell disease. So it's really important that we highlight how far we've come. We've had significant advancement in pediatric years with the invention of hydroxyurea, penicillin, TCD stroke screening, having more comprehensive care centers. All of these things have really helped, and penicillin prophylaxis, obviously, that have really helped reduce the mortality in pediatric years. So as you can see, this was back in 1979, that black line, there's a huge mortality increase at ages 1 to 4. And then it starts shifting to the right in 2017, and even now, shifting more and more, where we are having longer life expectancies, but the mortality is now shifting into that more 30 range. There's worsened US mortality rates, though, now for adults. As we're getting older and older and older, there's just higher mortality in comparison to the general population. And so I want to highlight that adult sickle cell disease is a chronic disease of slow end organ damage. And so it slowly progresses with multi-organ failure and decreased quality of life. There's chronic organ failure is a primary cause of mortality and is a cause factor of acute death. Autopsy data shows that 75% of chronic organ failure is clinically diagnosed and only 25% of the time. So we are more than far lacking. And then except in individuals at sickle cell centers, the median age can be 60 years, and the overall survival rate for adults is decreasing regionally in general if they don't have a sickle cell center. And so sickle cell disease affects a lot. So it affects the brain. And this is just some complications that I'm listing here. I can name another infinite amount, but you can cause stroke, thrombosis, hemorrhage, the eyes, retinopathy, retinal damage, marrow causing anemia and decreased production, lungs, acute chest syndrome, pulmonary hypertension, heart, thrombosis, diastolic heart failure typically, spleen, functional asplenia, splenic sequestration, biliary system with gallstones, hepatomegaly, kidneys, nephropathy, renal failure, bone, osteonecrosis, osteoporosis, genital system priapism, infertility, skin, leg ulcers, and then pain, the loudest symptom. But we forget all of these other organs that are involved when we talk about sickle cell disease. The thing that most providers remember is pain. The things that most patients remember is pain, because that's what they suffer from day in and day out. But we have to remember that it's a slow organ dysfunction. And so I like this graphic. I actually adapted it from Dr. Jane Hankins from St. Jude. But it just shows as you age, as an infant, I think Nurse Pat had spoke about this earlier, you're a blank slate. You don't have that many complications. As you get older and older and older, more and more organs start to be affected. And so it requires a lot more people on your care. And so not only are you medically more complex, but now you're navigating this more complicated health system that doesn't have the resources and doesn't have the time to spend on all of these different complications. And so not only do you have to now have an increased ability to advocate for yourself in this complicated system that is one not really able to withstand all of these chronic conditions that have now formed because of your sickle cell disease. So it's really, really, really important that you start doing routine health maintenance. So I'm going to take a pause here because I know I can talk for, it's an hour and a half long. Do we have any questions either here in the audience?
Yeah, so you touched on it, but one of the questions was pertaining to the sickle cell beta thalassemia 0 and alpha thalassemia trait. Could you elaborate a little bit more on that?
Yes. So with alpha thalassemia trait, it has been shown that there could be some sort of protection in terms of having your sickle cell disease not be as potentially complicated. And the reason why is that, remember how I talked about the hemoglobin molecule? You have 2 alpha and you have 2 beta. If you don't have as much alpha, if you have slightly less, I'm not saying zero alpha, just slightly less alpha, now your sickled beta can't form hemoglobin S anymore or as much. And so the ability to form now sickled red blood cells starts to decrease slightly, not completely, but slightly. But that ever so slight amount has been shown to have some degree of decreased severity of the sickle cell disease. Very minimally, but some degree less. And that alpha thalassemia in general is not detectable on hemoglobin electrophoresis. So I do want to mention that. There is some small markers that you can tell, and that could be suggestive, but it's not diagnosable. Oh, yes.
Good morning. I'm not a doctor. I don't even play one on TV. You remember that? But in looking at bone marrow and stem cell transplants, and a lot of discussion about the new stem cell transplants. The question I have is that for many people now, they have grown up with hydroxyurea. Their sickle cell crises are less. They're generally healthier, but they're a little bit too healthy for the transplant. They're not having a crisis every couple of months, 3 or 4 crises a year. And so the question is, what does the future look like for them? Are they going to continue with just hydroxyurea and once a year crisis and keep on going? Are there some plans in the future to be able to offer either a stem cell or bone marrow transplant to those folks, or a different kind of cure that will help stop the bone damage as well as the pain and the crisis without the, to me, the terrible part of, they call it making room in your immune system. That's not making room, that's killing off your immune system. But that's because I'm not a doctor, and I just know what people go through with the mouth sores and all of that from the busulfan. So your thoughts on what's ahead for sickle cell disease?
Dr. Patel, you want to answer this now or?
I can answer it now partially, and we can talk about it a little bit more. I know there's other sessions too that are going to talk a little bit more about gene therapy. But it's a very complicated question. I don't think that anyone fully has an answer about truly who is the ideal candidate. If someone is really well controlled on hydroxyurea, should we have them undergo busulfan, which can cause a lot of other complications potentially, and we don't fully have a long-term understanding of what these transformative therapies can do. And so it's going to be really based on the individual to decide, are those risks worth it for them? Or should, if I'm well controlled, should I keep on the known disease modifying agents? And so it's really between the individual, their caregiver, and the physician to really discuss. And at this point in time, it's going to be very individualized. Yes. And I think I saw one in the chat, but I don't know where it went.
Yeah, there's a question that a follow-up question to the alpha thalassemia gene genetic test. Is there a test that you could actually use to find out exactly if you have alpha thalassemia?
So you can do alpha globin sequencing. The question though is that, if you do have an alpha deletion, would it do anything to change my management? Probably not, right? You're going to either have decreased complications because you have that as a partial protection, or even if you do and you don't have decreased complications and you suffer from still very severe sickle cell disease, it's still not going to change my management. And insurances may not cover it. The only time where we're really going to be doing a lot of alpha globin sequencing is if you're doing the eligibility criteria for gene therapy. Because with the alpha globin deletion, they have been shown, depending on how many deletions, and it's more nuanced, that there are other risks. And so you would be doing more full globin sequencing at that point.
Thank you. Are joint replacements considered, oh, are joint replacements considered part of organ damage over the years?
That's a great question. Yes. And so, I mean, it depends on, what caused you to have the joint replacement. So a lot of times with sickle cell disease, you'll suffer from avascular necrosis. A lot of times in your hips, can be in your shoulders, but it can be in any joint or any long bone. And so over time, having damage slowly to your long bones can cause these avascular necrosis where you would need a joint replacement. But that's not to say that if you got into an accident and you needed a joint replacement, that's from your sickle cell disease.
All right, if it's okay, Dr. Patel, you want to continue with your presentation?
All right, and I know we're going to talk a little bit about routine health maintenance, I think, in some of the other slides, but I'll just kind of quickly go through this too. So health maintenance in pediatrics and adults are going to be obviously a little different based on age. And so I think this is the only one that I included from pediatrics, even though I med peds, I do mostly see adults now. But if you have SS or S beta thal 0, you are at higher risk for stroke. And so it's per guidelines that you start doing TCD stroke screening from age 2 to 16. Starting at the age of 10, you should start doing ophthalmology yearly visits. Well, depending on the age, but yearly visits in general for retinopathy screening. Dental screening should be done every 6 months. A urine microalbumin creatinine ratio to screen for sickle cell nephropathy should be done yearly, starting at the age of 10. And then vitamin D screen, this isn't necessarily per any great big ASH guidelines, but I personally like to do vitamin D screening every 6 months for good bone health and do also high dose vitamin C if needed. And then immunizations, it's really important that not only are you doing immunizations to help prevent against what we call encapsulated bacterias, so like pneumococcal and your meningitis type shots, but an influenza to prevent against acute chest, but it's making sure that you're seeing a primary care doctor as well, and that you're up to date on your tetanus and your shingles when you're 50 years of age. Go ahead.
In your practice, do you see any correlation with vitamin D levels and pain severity?
So that's to be studied. I think in script, Dr. Puri's currently, I don't know if she actually published it yet, but it was looking at vitamin D level and chronic pain level and did find an association. It's hard to say, though, is it a direct association or more of a correlation? I would say about 70 to 80% of the general population has vitamin D deficiency. And so when it's that high of a percentage, it's really hard to fully evaluate.
I could add to that. I think there is more pain in patients that are vitamin D deficient because a lot of times
We'll go on to.
the pain.
Oh, go ahead. Sorry.
Oh,
We lost
sorry.
you for a little bit, Dr. Blake.
Yeah, I think that I've seen it where once you treat severe vitamin D deficiency, the pain, especially bone pain, seems to improve.
All right, we have one more question.
Yes, thank you, Dr. Patel and Dr. Blake. Question regarding bone loss and dental care. Is there a higher percentage of bone loss with sickle cell warriors, especially regarding our teeth? I'm finding that in my life.
There's a higher degree of bone loss in general. And so osteoporosis is very, very common. And age of menopause is also earlier in individuals with sickle cell disease and even an iron overload. And so if you're using general screening of when to do it just for the general population for DEXA scans, it might be too late. And that would be general bone, including oral as well. And I found actually recently, and I know reports are low, is a lot more avascular necrosis of the jaw. So I know at some point we'll look more into that, but there's only been not as many reports, but I have seen that quite a lot since I've started working here at least.
I think we have a couple more questions.
Is this better? There we are. Okay. What, if any, advances have been made in the standardization around health maintenance to include neuropsych evaluations when we understand the historical or the cumulative impact of nocturnal infarcts?
That's a great question. There is NASEC, so the National Alliance of Sickle Cell Centers, that are coming up with more consensus guidelines. I think some of the challenges, as we know, is that in, let's say, oncology, where you're focusing on cancer, or cardiology, there's so much research, so much data. And so when you come up with consensus guidelines, it's very high evidence-based certainty. I think when ASH created their guidelines, it was, it definitely helped because we had no sickle cell guideline. I mean, we had the NHLBI in 2014, ASH guidelines in 2020. But there's still so many questions, right? What health maintenance should be done? What should be standard? And every different institution is doing something slightly different. And so we do need that standardization. And so NASEC's kind of forming a group to determine what health maintenance should be standard. Should we be offering neuropsych testing? And there's a whole neuropsych work group discussing this. I think one of the biggest things, though, is lack of resources for full neuropsych testing at every single center. But if we make it a guideline, that might push for advocacy to make it more available.
Yeah, along the same lines, TCD screening was never in the hospital's radar because it was not part of the top hospital grading system. And recently that changed, that if you don't do TCDs for sickle cell patients on a regular basis, your hospital is not going to get a high score. So that is along the same lines. The resources come once guidelines are made. We had a question here.
Oh, no, I just want to know if you could go back to the slide you had before this, because the one that told us what we should be taking.
Oh.
Is that the slide? Oh, I'm sorry.
No.
No. Oh, I'm sorry. The one that you had at the end, the last one you showed, but the one before that where it showed what we should be doing, you know, what kind of testing we should be getting. The maintenance. Yeah, I think that was it.
The electric.
Yeah, she went
Okay. Okay, sorry, this is like a lot of.
Was it the electrophoresis test?
Go back to where you were, and it was right before that.
This thing?
Health maintenance. Yeah. Yes, that one.
Okay.
Thank you.
Okay. What's your
No, I wanted to take a picture of it.
Oh. I think we have a question here, and then I'll come to you. Okay. Maybe I'll stand right in the middle, so whoever
Thank
wants
you.
to ask a question.
Okay.
Oh, stand with it.
So, hi, good morning. Thanks for being here. Does the, are there other, how do you get a high shot of vitamin D? I mean, besides taking it orally, is that what you meant by high doses? Like,
It's taking it orally. So instead of
Okay.
doing daily supplementation, which I found in my patients, if they're even like when I am prescribing it daily, it's not really increasing their levels as well. And so I always prescribe high dose. And so it's
Like
once a
1,000?
week. It's no, yeah,
1,000?
yeah,
50?
50,000.
A pill?
Yeah. once a week.
Really?
Yes.
Okay, thank you.
And so I do that instead. And then when I end up doing that high amount, I end up just checking it every time I do their hydroxyurea labs every
yeah.
3 months.
Yeah.
And so I just make sure that we're not going to too high of levels. But typically, that's very, very rare that even when I just continue someone on high dose once a week, that I ever get to too high levels. I think that's happened in one of my patients.
Do you think that would help with the constant pain around in the back?
It can.
Okay.
It may or may not, but it's something so easy that could be done.
Yeah.
That might as well let's make sure that your vitamin D is adequately supplemented.
Thank you.
You're welcome.
So are we supposed to say our name? Are we supposed to say our name? Pat Corley. So I see that you have these routine health maintenances, and Dr. Johnson and I did this years ago with the routine. I'm just wondering, do we actually disseminate this information where those docs out in the communities and stuff really know what routine health maintenance looks like for folks in different stages of aging in the sickle cell community? Because I seldom hear docs talk about, all of the different things that we talk about in centers of excellence, quote unquote, whatever those things are. So I think it's really, really important, since we're sending people to primary care docs, that we ensure that primary care docs understand, because the healthcare system wants to save money always. So, oh no, you don't need this. Oh, you had this last year, you don't need this, So patients need to know that these are the things that need to be done on an annual basis. And doctors need to know that these are the things that need to be done. And I think we have to be more diligent about getting that information out to folks so that they truly understand what the guidelines say. Because most of the docs, even when you take them these guidelines, I bet you if you polled them to see how many of them actually review or read them, and know this information, there's going to be very few of them. And then the patients have to argue with them about the things that they've been told are necessary for them to have. And then there's no screening on here that talks about like, this only talks about regular health. It does not talk about women's health,
Yeah.
It doesn't talk about men's health and screenings that need to be done in those arenas.
Yeah, there's a lot of different health
Yeah,
maintenance.
yeah.
And that's a great point. We really need to be disseminating this information on how to truly do a comprehensive annual visit. NASAC is coming up with those general guidelines, but it will take a few years for them to have general consensus, because even different sickle cell doctors might have different ideas. I know that TCD work group session at NASAC was a very long session with very different institutions doing things differently. And so I think it's definitely very, very needed. One, we need to come up with a great consensus of what really needs to be done. I think I put the least controversial ones in terms of consensus on here. But we need to be talking about this and really disseminating that information. Yeah, it's not, the problem is, yeah, I put that for every 6 months, but again, it's not covered, right? And so most of our patients don't have dental insurance. So when I'm referring my patients, I said, hey, you need to see a dentist. I'm concerned that you have a dental abscess. They don't have someone to go to. And so, and when I've called many different dental facilities to try to figure out low cost, they're not low cost. There's no such thing as low cost dental. I think every single time I go to the dentist, I'm spending thousands of dollars. So yes. Okay. Yeah, that's true.
That's something that's not utilized enough. I'm coming. We always talk about things we don't have in our, in our settings, but those dental schools are instrumental because the dental students need to learn about sickle cell and dental health. And so those are some of the things that we need to kind of you know, as we're trying to pack our bag to make sure that we unpack all the things that people with sickle cell disease experience, we have to pack those bags that provide resources for them to be able to get those things, like the school of dentistry, and you know, just inviting medical students to participate in things and
Yes.
stuff like that can make a difference in our community.
I agree. And I think this is why it's really important that medical providers should really collaborate with CBOs, because there's resources that, you don't learn all these different resources in medical school. You learn it over time. And having some organizations that's been doing it a lot longer than you, have been in the area a lot longer than you, that's where you really know how you can best help your patients.
Okay, good morning, everyone. I don't know if you've ever had a dietitian involved in your discussions, but I'm a dietitian. And one of the concerns I have, and it's tough, even treating people who don't have sickle cell anemia or the trait or anything, I am now seeing and understanding how much nutrition affects health. And unfortunately, what we call food a lot of times is not food. It's so highly processed. It's so high in added sugars that it affects, outside of sickle cell, it affects your health. How much of a discussion are we having with our sickle cell patients? And I ask that because, again, it's a tough situation when they come into a hospital, because I manage nutrition services at Loma Linda. When they come in and they're in a crisis, all they want to eat is junk. And I'm saying, this is just making a bad situation worse. It's it's something that I don't even know how to, because I don't want to deprive them. They're already in pain. It's
Yeah.
not the time, you know. But at the same time, I'm just wondering how much of a discussion is being had with these patients to understand that, yes, this is what you crave, but this is just making you worse.
It's something that I very briefly talk about, but with my visit, I don't have that much time to go fully into it. And so that's where I say, hey, when someone's really interested, this is where I refer to some of the community partners and community healthcare workers to be like, this is and a referral to nutrition if they're that interested. But this is something that we need to discuss, and maybe we need to partner with other people, because as a physician, it's really hard to have all of these different conversations. Healthcare and an individual's health, only 10% is impacted in the healthcare system.
Right.
90% is impacted by everything else in their life. And so I can only make 10% of that difference. And then I need the support for that 90%.
So, and thank you for that response. And even to my earlier question about the integration of periodic neuropsych evaluations as a part of routine health maintenance. But I wanted to offer a practical piece for consideration and then expanding more on what colleagues just said here. One is, I'm wondering, as we are disseminating the information of ASK and the actual guidelines, how do we also be intentional of saying emerging guidelines or emerging considerations, so we can begin to bullet these other pieces that still warrant more research for consensus, because we also know that there's a systemic problem with getting the research for consensus that goes into more than we can consider here today. So if we keep waiting for the consensus to happen, the lives are not getting what they need. But maybe if we can be intentional to add a both and, here are the actual guidelines and here are other considerations. So both are being presented at the same time, that may spur more activity on the emerging list. And then the spirit of this practical is coming from something I'm hearing in the group here too, is again, because of how our healthcare system is set up and the levels of disparity that this particular group uniquely interfaces, as well as the healthcare providers. So I just want to love you all up that you continue to do this work, because you're not getting accolades, a lot of money and stuff like this. My point is this: from the beginning, we have to be able to strategically coordinate and partner with dental schools, with like where these sites are, like that should also be part of the guidelines, not the actual what you do, but how can the guidelines and how can others kind of start those leverages of conversations, because dental students need to practice, and that's going to be a wonderful way for them to practice and learn. Nutrition, I mean, these are all coming up, folks, right? And this is a wonderful group to begin to partner with to do that work in a respectful way.
Yes, no, that's a great point. And we need to reframe the way we word this so that we're not just talking and waiting for the future. We need to start acting now.
Just a response to that, I feel they talk about the hub and spoke model. Patients who go to big centers have more access to these things that you're talking about, whereas patients in the community sometimes who don't have access to a big medical center don't have access to these things. The ASH website does have areas of importance of research and clinical care on it. But again, those not many people in this room are going to ASH website. But yes, those guidelines are there, and also what are the areas that need to be developed going forward are on there. And as clinicians and researchers, we look at those when we're thinking of research ideas that we want to improve care in, and we say, oh, does the American Society of Hematology also recognize this? And if it does, then we work on those things. And it takes time, but that is the work in progress.
So I'm not going to give us any grace. We've been around a long time. You guys are new to it, but the work in sickle cell disease has been around for a long time, and we're still reciting the same story. And there are some instrumental things that need to be done, particularly dietary information for people with sickle cell disease. There is no reason why every individual with sickle cell disease should not have a dietary evaluation, so that we can then begin to teach them how to do better. Because I can tell you that when our individuals with sickle cell disease used to come into the hospital, guess what they left the hospital with? Sodas and cookies and all the things that they should not be eating to improve their health. But they did it because it gave them a pop of energy. So those are the kind of things we need to talk to them about, the dental stuff, sickle cell disease does have an effect on your dental status. So they need to understand those kind of things. Families need to understand those things. And we are missing a lot of targets, that dental health thing. I used to send the patients all the time to the dental clinic. Oh, USC has a dental school. Let's talk to USC about getting you over there. They didn't have dentists in the community. Sometimes we could recruit dentists who would do some help with some patients because we pull on their heartstrings. But there are just a lot of things that are missing in our guidelines, in terms of ensuring that individuals with sickle cell disease really truly get and prevent some of the things that happen to them, so that we don't have to go back and try and fix all those things all the time. The pregnancy, people with sickle cell disease having children with sickle cell disease, because we're not emphasizing things enough. So we have to really get to work at doing what we do and do a better job on what we're doing, so that we can ensure that the patients can do a better job of taking care of themselves and living well with sickle cell disease.
Yes, thank you.
A response to that, every sickle cell patient needs a sickle cell specialist and a primary care provider. They don't need one or the other more. So all those things you're talking about, that is general good care for patients, right? They need general care in addition to specific specialized sickle cell care. And a lot of our patients are not going to one or the other. And so in pediatrics, by law, everybody has to have a pediatrician, but there is no such law for adults. And so it's really hard for our adults to find primary care providers who would do all this general healthcare maintenance, which should be required by law.
That's so crazy to me that this is a disease that shows. I'm sorry.
No, nobody can hear you.
Nobody can hear me, but my pet peeve, and I could stand on top of Mount whatever, the highest mountains around, and yell it out. The thing that most bothers me about sickle cell disease care, sickle cell disease is a disease of pain. There is no individual with sickle cell disease that does not experience pain at one point or the other. And yet they never get pain consults. Why don't they ever get pain consults?
There aren't providers.
So-
I 1000% agree. I refer and it goes nowhere.
Yes, I don't understand that.
That's why.
That to me is poor care. That's negligence. So why do we not insist that people with sickle cell disease, from the time they're little kids, they should be getting those? You know, they're the one group of patients, their disease is punctuated by pain. And they're the only group that I know that is routinely denied pain consults.
All right, we'll take one more question and we'll go on with the presentation.
Mine is not a question, it's just a response. It's been mentioned by a number of speakers. So much of this stuff comes down to money. And we're talking about, especially if we're talking about adults, because how many people, here's the whole go around thing. They're no longer living with their parents. So now they get insurance basically through jobs, but they're too sick to have a full-time job. So they are living in their cars and going to the emergency room from time to time as needed. Why is this? Because people don't give a damn. I'm sorry, but if people cared, more stuff would happen. So my thing is to everybody in this room, this is not the first time we've been in rooms like this, talking about things like this. Each one of us, I'm going to say, I will promise that I will do what I can, I will continue to do what I can to raise awareness, to talk about some specifics about treatment guidelines for adults that everybody knows that we put out maybe through the Cayenne Wellness website, that we start with ways to make sure that adults know what the treatment guidelines are for them. If there are not national treatment guidelines, then we go to NIH, we go to NASM, we go to those groups. Each one of us in this room has to do something, or we're going to be here. I'm sorry, I gave a talk at UCLA in probably, it's been maybe 15 years ago, and I talked about the discrepancy between money spent for cystic fibrosis and money spent for sickle cell. It's the same damn thing. And I was talking to people who were the movers and shakers. It was sponsored by CIRM. It wasn't like I was talking to nobody who could do anything, but here we are. And we have to double down and make our voices heard, be consistent in what we're saying, make sure that we have equity in opportunities, equity in insurance, equity in guidelines that are followed by everyone, equity in what hospitals do. We still have hospitals, when a sickle cell patient comes in, they sit them in the hallway without even a blanket. It's one thing to say, well, I'm not sure about giving you opioids, but wait a minute. How bad is it? How hard it is to give the person the damn blanket? I will stop now.
Or water or heat packs.
But
in the winter.
I hope all of you will leave here energized to do more of what all of you have been doing.
Thank you.
Just on the, if there is a group looking at the guidelines for the, like adaptive functioning testing is a child, which should be happening routinely, at least in California, it needs to be the Vineland test. Because if they're kind of failing the Vineland test, they might have a chance at getting regional center services. but they have to have the Vineland test. They won't accept the other tests. You still have to take it. So why not just go for it? And regional center, I didn't even know about the regional center until my son was in 24 or something. I had no idea. I was like in despair because he was in such pain and always going to the hospital. And I was actually out of town working and stuff. And some other passenger on the airplane told me about the regional center. It's like, what? We should be getting, our son got, after a lot of fighting, regional center services because he has other disabilities too, but why not push and get regional center services for those who need it for sickle cell patients?
That's it.
Costs money.
Well, yeah, but that's the 5th category.
Yeah.
The more people that get it, there'll be precedent.
No, I agree.
Great. We'll move on with your presentation.
No worries. All right, that was a great conversation, and I really wanted to make this session interactive because otherwise I'm just talking to a blank room. So I'll go a little bit quickly through some of these slides, but my biggest point that I like to make is that there's tons of health screenings that can be done. And I also don't want to burden the health system with unnecessary screenings because there's already, like we said, so many lack of resources. Let's burden it where it is needed. And so we really do need to be screening at every single visit if some of these tests need to be done. This isn't just a one-time initial visit. Let's ask if you're having any of these symptoms. It should be done at least annually, if not more. And so making sure you're doing a very comprehensive review of systems. And then if anything is flagged, making sure you have a very, very low threshold to obtain echocardiogram, PFTs, a 6-minute walk test, or a sleep study. Very, very low threshold to obtain a DEXA scan. If your 29-year-old, 30-year-old patient is postmenopausal, if they've been on Depo-Provera since they've been 13 years of age, for males in terms of DEXA scan screening, we should be doing this a lot sooner. And so making sure that we are aware and have very low thresholds. ASH guidelines recommend MRI brain with and without contrast, at least once as baseline. I found that sometimes it can be challenging for insurances so all of them cover it, but I always at least advocate if there's any concern for cognitive impairment or any concern for vascular abnormalities that had been previously seen on imaging, that MRI brain is done. If you should be screening and trending ferritin levels, especially with those who've had a history of significant transfusions. And you should be ordering MRI abdomen in order to evaluate liver and pancreas iron quantification. And if the liver iron concentration is greater than 15 mg per gram, or if there's cardiac dysfunction noted on echo, you need to make sure you're ordering an MRI cardiac. And then making sure every single visit you're assessing where that patient's pain is. And if they haven't had x-rays of their hips or their shoulders and they've been suffering with pain in their hips and shoulders, you better make sure you're screening for avascular necrosis with an x-ray. And if it still doesn't show it, making sure that you're ordering an MRI. And just a quick point about that is that I know core decompressions can be, depending on the institution, depending on the orthopedic doctor, can differ. But when it's a very early onset avascular necrosis that shows up on MRI, that's been the only time in evidence that really shows that core decompressions can be really helpful. So early screening can potentially help delay joint replacement for a while. Correct. Any area that is having pain, I'm getting x-rays. I do it every visit. This is why my visits take an hour plus. But I think NASAC in general are recommending annual comprehensive visits. And I think Dr. Bisson also does it every visit. A comprehensive visit is done every time. So targets for sickle cell disease therapy, basically it's with every single component of the pathophysiology that causes sickle cell disease complications. So there's many areas of target. Just the caveat with gene therapy, you're not, at this point, we're not actually changing the gene mutation. So that's not what these two FDA-approved gene therapies are. But gene therapy, the hopes is that eventually we will do more base editing. So it's really important we optimize sickle cell disease modifying agents. The very first disease modifying agent that's been FDA approved is hydroxyurea. It's been out for a very long time. And so it increases hemoglobin F. It really it decreases inflammation. So our targets A and C is 2 to 3. And the goal is to really titrate up to maximum tolerated dose. This part is key. If you're on a very, very low dose of 500 milligrams daily, that might not be enough for you to see full effects. And the effects, again, they're not just helping decrease pain. Effects, so clinical endpoints, it can help increase hemoglobin by 1 gram at non-myelosuppressive doses. It decreases pain, but also decreases your risk and frequency of acute chest syndrome, decreases hospitalizations. And the biggest thing that I like to stress is it decreases organ dysfunction. And so it's known to improve persistent microalbuminuria, splenic dysfunction. For individuals, children who had abnormal TCDs, you can switch off of exchange or simple transfusions to hydroxyurea potentially with screening of TCDs afterwards. It can help with neurocognitive delays, it's been shown, and also help with pulmonary arterial hypertension. So it's really important that we stress it's not just to decrease pain crises, and it's really also to help improve organ dysfunction. And this is the only FDA-approved therapy that we know does this. The other ones have not been out long enough. So Oxbryta or voxelotor, it is inhibition of intracellular hemoglobin S polymerization. The main clinical outcome is it improves hemoglobin concentration. So compared to baseline hemoglobin on Oxbryta, 42% had an increase of 1.5 grams and 27% had an increase of 2 grams. And those decreased signs of hemolysis. L-glutamine and DARI, it's inhibition of oxidant stress and inflammation. I think of it as taking a blueberry or strawberries. It really helps with the antioxidant properties. So it improves your red blood cell health. So clinical outcomes at 48 weeks, you decrease pain crises by about 25%. And there's only been one big clinical study for Endari. They haven't really done more studies beyond the one that made this FDA approved. It reduces frequency of hospitalizations by 33% and also decreases acute chest syndrome. And then crizanlizumab, it's a P-selectin inhibitor, so that helps with the stickiness. And so helping decrease what they found in the first phase 2 trial of SUSTAIN was that it decreased median time to first and second crises, and it also decreased hospitalization frequency. The STAND phase 3 trial that they had talked about their findings at this last ASH was that they actually showed no significant difference in pain with crizanlizumab. This was more of an international cohort though, and so I think that kind of confounded a little bit of the results. And additionally, I would say from what I've seen just personally treating individuals with sickle cell and crizanlizumab, it helps in about a third of the patients really decrease crisis frequency. The other 2/3, it either has no effect or it might make their pain a little bit worse. But for some individuals on it, it really does help. Spartan phase 2, it does show that it could potentially reduce priapism episodes and events. So this is just a quick graphic of all of the disease modifying agents and what they do. I won't go through it because I talked about each one of them, but I just want to stress hydroxyurea again is the only one that we know. The others can, we just don't know it, decrease organ dysfunction. So chronic transfusions, it could be simple or exchange transfusion. The challenge with simple transfusions persistently is that you can have complications of iron overload. Indications are for stroke prophylaxis when an individual already had an overt stroke, or if you had an abnormal TCD. Goal is to decrease your hemoglobin S to less than 30%. Then there's been other indications that again, depending on the individual, depending on the provider, then you talk. Is chronic transfusions something that you will benefit from? And so if someone had, and what I mean chronic is scheduled regular transfusions every 4 to 6 weeks, whatever that frequency is, to keep your S percent less than 30. So if you had significant history of constant acute chest syndrome, it potentially could be an indication, knowing though that transfusions do have its own set of risk. And so it really needs to be an individualized approach. Pregnancy. There's no clear consensus on whether there should be a routine scheduled chronic or simple exchange transfusions, but it could be a discussion depending on your individual complications. Pulmonary hypertension, that's another one, and then severe vaso-occlusive episodes. So I'm gonna talk about the NHLBI consensus guidelines regarding severe complications of sickle cell disease management in patient. And so for strokes, cerebral vascular accident, so types of strokes, children more commonly experience ischemic stroke. And so some of the symptoms could be sudden onset of hemiparesis, aphasia, facial droop, or occasional seizures. Adults more commonly experience hemorrhagic strokes. You can have severe headaches, altered level of consciousness, seizures, speech problems, and or paralysis. And this is not to say that a child couldn't have a hemorrhagic stroke or an adult couldn't have an ischemic stroke. Diagnosis, if you have any level of concern, very, very low threshold to get a CT scan, and then follow it up with an MRI and MRA. And it's an emergent exchange transfusion. Anytime there's any concern, it's a need for an emergent transfusion. Acute chest syndrome, so it resembles a pneumonia. A lot of times it's hard to really even differentiate. So I always say if it's a pneumonia, I'm going to presume it's an acute chest because you want to make sure you're monitoring very closely. So it's signs and symptoms of a lower respiratory tract infection and a new pulmonary infiltrate on chest radiograph. You have a higher risk when you're hospitalized having a vaso-occlusive crisis after any surgical procedure where you're laying still and not breathing as much, and then any individual with prior history of acute chest syndrome or asthma. And so it's really, really important that you're using your incentive spirometer when you're hospitalized for a vaso-occlusive crisis. I always say 10 times when you're awake to really prevent that higher risk of developing acute chest syndrome. And in terms of evaluation, if you're concerned, making sure your oxygen levels are being monitored, that you got a chest x-ray, and that you're obtaining basic blood work, so CBC, retic, and a blood culture, especially if you're febrile. With acute chest syndrome, you're going to be treating it with antibiotics, making sure that you're giving the appropriate respiratory support. You can consider a simple transfusion, especially if your hemoglobin concentration is below your typical baseline. And then if you're developing rapid progression, you should really consider urgent exchange transfusion. And so priapism episodes, painful erections that can happen in our males. About 1/3 of boys and men are affected by priapism. Multiple self-limited episodes may be a harbinger for greater than 4 hour worth of an episode. And so treatment, so if it's more than 4 hours, that's considered an emergency. So you should initiate oral and IV hydration, depending on their volume status, IV analgesia, and an emergent urology consult for aspiration. And then if refractory, even still, you really should be considering exchange transfusion at that point. Multi-organ failure. So this presents rapidly and unexpectedly, and so it's unexpected deterioration. And it typically occurs in adults who have severe vaso-occlusive crises. Signs are developing fevers, rapid decline in their laboratory markers, so hemoglobin and platelet count, non-focal encephalopathy, and you diagnose it by 2 out of the 3 severe organ dysfunctions, so liver, lung, and or kidneys. Treatment is exchange or simple transfusions, and then supportive care as well. Splenic sequestration. So it's sudden enlargement of the spleen with reduction in hemoglobin concentration, by at least 2 grams below baseline value. And I do have to add that now, since hydroxyurea has been utilized as early as 9 months of age in pediatric years, our sickle cell individuals are keeping and sustaining their spleen. They're not having as much asplenia or splenic infarcts. And so we're seeing a lot more splenic sequestration in our adults, which previously had not been seen as much. So we need to make sure that we're aware that it's not just something that's happening in the pediatric years anymore. So consistent laboratory findings is elevated reticulocyte count, circulating nucleated red blood cells, and decreased platelet count. So you palpate the spleen, and ultrasound can be useful, especially in our adult patients when it can be challenging at times to palpate spleen. And then making sure you're transfusing. So not transfusing too much, but transfusing 5 mLs per kilo for worsening anemia, IV fluids if hypovolemic, and considering a splenectomy, depending on if this has been recurrent or other factors. And then you can have hepatobiliary complications. And so this is the hepatobiliary system, and a lot of things can be affected. So acute cholecystitis means inflammation of the gallbladder. You have acute choledocholithiasis, which the gallstone then came into your common bile duct right over here, and that caused blockage. And so now you're having your liver being affected and your liver enzyme being affected, as well as having that severe right upper quadrant pain. Biliary sludge, and so that's just more thickening of your gallbladder wall. Acute hepatic sequestration, which is instead of your spleen sequestering blood, your liver sequestering. And then acute intrahepatic cholestasis. So that's characterized by sudden onset of right upper quadrant pain, increasing jaundice, progressively enlarged and exquisitely tender liver, extreme hyperbilirubinemia without common bile duct obstruction or cholangitis. And so your initial workup, especially if you're concerned about this, you should really be doing a CBC, a BRTIC, a complete comprehensive metabolic panel, and then also adding a direct bilirubin. So you're analyzing your total and direct bili, doing that right upper quadrant ultrasound. And then if you're suspicious of complications of choledocholithiasis, you should be doing an ERCP to retrieve that gallstone. And then treatment is going to be your typical management for gallbladder. So I would have to say pretty much most hospitalists are very comfortable managing gallbladder complications. But the thing that's more specific for sickle cell is the acute hepatic sequestration and the acute intrahepatic cholestasis. And so at that point, if it's more severe, you should be performing simple or exchange transfusions as well. All right, we'll take a quick, I know it's already 12:15, so we can either do one question or we can continue. Great. So one of the things I wanted to highlight is that I've been in pain for a few days and the medication isn't working. I am going to have to attend that horrible place I don't really want to go to. This is how our patients feel about the hospitals. So it's really important that providers know they don't want to be there. I think it's just a lack of color. I'm just stealing this from Google. You're right, though. So this is a vaso-occlusive progression of a painful crisis. And so it starts off slow and then to a point where now it's no longer sustainable at home. And it gets to the point where it's now irreversible. So an individual presents to the hospital. And this crisis, if they're not treated aggressively initially, it delays this arc. And so you have a longer and longer progression of a vaso-occlusive crisis. And so typical crises, when it's severe, that plateau phase is 3 to 7 days. And as you get older and older and older, when you have your acute crises resolution, it's not truly a resolution anymore. That line in the middle, you're having less and less pain-free days. And so you might not ever return back to what your prior baseline had been. And so I kind of took a lot of the PowerPoint power deck from ASH guidelines as we talked a little bit more about pain management. And so acute pain for sickle cell disease can start as early as 6 months of age. As you can see on right, this is swelling of the hands, dactylitis. It's the most common cause for ED visits and admissions. Pain management affects future coping, which is huge. If you provide bad care, if someone's pain is not treated, that burden lives with them throughout future hospitalizations. So you need to make sure that you're providing what the patient deserves in terms of basic standard of care. It typically affects long bones. So low back a lot of times can be a common site, but it can occur anywhere. The scalp, the face, the pelvis, everywhere. Warning signs for complicated sickle cell pain. The biggest thing is when people are not, they say someone's coming in for pain and that's it. They assume it's a vaso-occlusive crisis. It's really important you're looking at some of the warning signs, their respiratory status, fevers, abdominal pain, weakness, lethargy, and any sort of like worsening icterus. So treating all pain the same is like treating all forms anemia with the same approach. You really need to determine the etiology of the pain. And so for, in general, ASH guidelines, they recommend rapid giving assessments and administration of analgesia within 30 minutes to an hour. And then you can utilize non-IV routes as well in order to administer pain medications faster. They recommend an individualized approach, so having individualized pain plans. And you should really have shared decision making when coming up with these pain plans. So involve the patient with the plan, create these plan as an outpatient setting when they're not in a stressed environment, have and talk about overall goals of the pain plan, making sure that you're making a more simplified pain plan so that someone can easily follow it and not making it where they're on 10 different medications at the same time. Use adjunctive therapy. And then it is a big push to try to start avoiding IV Benadryl, especially IV push Benadryl, unless they're having an anaphylactic reaction or if they've had some severe sort of allergic reaction in the past. Yes. So a lot of times, so in general, Benadryl is, or pain and pain medications, when they cause itchiness, it's not a histamine reaction. So it's not a histamine response. Benadryl is an antihistamine. And so we try to avoid it because it doesn't act on that same mechanism. What it does do a lot of times, it causes that synergistic effect. And so when you give IV Benadryl, you're at higher risk of having higher sedation, even though it feels like your pain medication might be working better because it has that synergistic effect. So we want to really make sure we're giving proper analgesia at the same time, not oversedating our patients so that they have that respiratory depression.
Additionally,
Sorry, we have a
the
question.
Benadryl has been shown to, especially in patients with silent strokes, can increase memory problems and also add to their behavioral issues as well.
There's one more question.
So my biggest concern on that is what patients get is a kickback of folks believing that they get a rush, they get a high from IV Benadryl. And so the thing that I hear people talking about with IV Benadryl, you're looking at the patient, they're obviously scratching their skin off, they're scratching from the top of their head to their feet. And I don't know why we allow them to get there, because my feeling is why don't we treat, we know that this is something that happens with this patient every time we use this medicine, and yet we don't cover them for that in advance, so that we don't have to play catch up trying to get that itching to go away. And so, and then it becomes a power struggle. I'm not going to give you any IV Benadryl, and I've heard doctors say it over and over again, because that rush, that you get from it, it makes them feel high. And so there's a big fight behind IV Benadryl, or, whether we should do a drip, or whether we should do this, or whether we should do that. When in reality, we know that we are the ones that are given the medicine that is causing the itching to come on. And why don't we prevent that from happening from the very beginning? It's crazy to me that we have to struggle with patients because we created, an issue, and we create it every time they come in the hospital. So how can we, when we know the patients are coming to the hospital, how can we give them something that prevents that itching, or at least lessens that itching, before we start giving all the opioids, and so we don't have to struggle with what we've been taught is what we should not allow them to get high off of the Benadryl. It's crazy. It's insane. And it's irritating. And it makes people feel like less than, Is this what you would do for a cancer patient that was on the same medicine and that was itching? No, it's not. And so I just think we just need to be more considerate of this population. I know they may not be as educated, they may not be as accomplished as some of the patients we serve, but we certainly need to give it our all and ensuring that they get the same humane treatment that anybody else gets.
And I think it's really important that I think using IV Benadryl prophylactically for any individual initially when they're pediatrics and we don't know what their side effect is, I think that's one area of potential disservice. Two, once they have it, we need to really address it, right? Does that mean we start either try oral Benadryl or oral hydroxyzine or do low dose naloxone infusions? Or what else are we doing to fully address? Correct. But even do it on first dose, right? So with your first dose of Dilaudid in my plain plan, I write IV Dilaudid this milligram, give with first dose this dose of oral Benadryl. And so that you're doing it simultaneously.
So I prefer the use of loratadine since it doesn't cross the blood-brain barrier, and that seems to help to prevent some of the secondary side effects of Benadryl. We're actually working on there's studies that was published in the anesthesia journal of low dose Norcan along with Benadryl, along with the opiates that would help to reduce some of the secondary side effects of the opiate. And so we're looking to implement some of that in our pain management plan in my hospital. And so those are some of the things. So we could look at other journals and other publications that have best practices and implement some of those. But also on the other hand, there's a lot of resistance from patients as well. You bring up different things, and patients have resistance to change.
Patients have resistance to change because they have resistance to suffering. And we have made the sickle cell population that way. We allow them to suffer for long periods of time while we make decisions that they're not even involved in. They're not at the table on them. And it is ridiculous that we know they're going to have itching. I mean, that's a side effect of that medication. So why is it that we don't teach patients how to pre-medicate or do something that will prevent that from happening. It just is insane to me, you know, as an African-American woman, the healthcare system is failing people of color because they are not addressing the reality of all of the racism and all of the sexism and all the other things that happen within this system. And then we, you know, we put on these blindfolds and pretend that we don't see that this stuff exists and that patients aren't going through this and that people aren't making judgments about them and saying things about them. I've sat in rooms where I've heard them do the damage. And so I know that, you know, I know we're talking about we don't want them to be drug addicts, but do we want them to have any quality of life? Do we want them to be able to function every day? We need to stop playing and be real with people with sickle cell disease about the reality of why we do what we do and the way we do it, you know, because it's not right. It is not right for
I agree.
people
I
of
think
color.
we definitely need more education, more research in terms of what would help with opioid-induced pruritus. I do have to say with IV Benadryl specifically, it's a hospital-wide push, not for just sickle cell disease, but they're getting rid of it for every single patient, every single disease, every single, and so it's just because of a lot of the other complications with it. And so it's not just sickle cell, it's a whole hospital-wide initiative. But I know there's a lot to talk about IV Benadryl. I think at every single conversation, because it is one of the biggest, I would say, divides as medical system is moving one way for IV Benadryl for all patients, not just sickle cell. And I think our warriors are having different say. And so I think that's one of the big things with Huge Divide, that we do need more discussions, more research, and more education about this concept.
And I think we should continue this conversation in our implicit bias talk next. But these are great points.
I didn't know. This is a very 101 quick. I didn't talk about fever, which is also because that's more of I guess I would say a hot topic, depending on if you're asking a pediatric or an adult provider. And there's a lot of different things.
I think we're out of time. So so maybe, do you want to close your talk with a few?
Yeah, so we can just go to the ending. So one of the big things is chronic pain in adults, and then a lot of the mental health component of it. But I'm gonna go. All right, conclusion.
Sorry, y'all, but you guys had such great suggestions that
you did. So sickle cell disease affects every organ system, and a comprehensive approach is needed. Don't assume that every sickle cell pain is a vaso-occlusive crisis. Treat vaso-occlusive crises aggressively initially, and then you can slowly wean over 5 to 7 days. And then more than half the adults living with sickle cell disease suffer from chronic pain, and it's your job to provide holistic care.
Thank you, everyone, for a great session. Yes, we'll put this on the website. Yes.
Yes.
Right. Thank you, everyone. So now it is lunch.